today's talk. My name is Jean Doak. I am a psychologist and I am the clinical director at University of North Carolina Center of Excellence for Eating Disorders. And I'm also the deputy director of the National Center of Excellence for Eating Disorders. Main differentiation is that at UNC, we are a clinical research and teaching institution. And with NCED, National Center of Excellence for Eating Disorders, this is a grant that's funded by SAMHSA with a primary purpose of providing education, information, and resources around eating disorders. So I thought I'd just take a little bit of time to describe both of those entities. For today's talk, what we're going to be covering will be a review of eating disorders and their diagnoses. I thought we'd spend a little bit of time differentiating ARFID, which is an eating disorder, from picky eating. It is a common question that we get clinically and within our referral process. I added in a case example specifically related to ARFID, and then I also included resources that would be helpful, not only for ARFID, but for other eating disorders and also for other disciplines who might be working with eating disorders. And as far as the frame or structure for the day, I plan to try to talk for about 45 minutes or so, and then use the remainder of our hour for any questions and provide any answers that go along with those questions. If there are questions I don't have the answers to, I will follow up via email and provide either additional information or additional resources to augment those answers. The other thing that I wanted to describe as far as the frame, in previous years, whenever I've given this presentation, I've gone through the eating disorder diagnoses and discussed the treatments associated with them, talked about the increased prevalence rates as a result of COVID, and then also discussed the impact on age and gender referrals as a result of COVID as well. Instead of providing the exact same talk, what I thought I'd do is add in the additional detailed anecdotal and experienced information that we've received since COVID, and would primarily the reason why I've wanted to focus a little bit more on ARFID. Over the last couple of years, we've seen a skyrocketing in referrals for younger individuals potentially diagnosed with ARFID and other co-occurring GI disorders. So I thought it was just timely for this talk that we spend a little bit of extra time on ARFID within the context of eating disorders and their treatments. So just some facts about eating disorders. Some of this you may be familiar with, some of it not. So just in case, I thought it would be helpful to review. So eating disorders impact millions of individuals and families every year. And this is, I will admit, this is probably now dated information. This was information obtained in 2020, just a few months after COVID had started. And so I would imagine that if this information were obtained 4 years post-COVID, that the numbers will be qualitatively and quantitatively different for a whole host of reasons. But at the time, the numbers indicated that about 28, just under 29 million Americans have or will have an eating disorder at some point in their lives. And that the result of that is about 10,000 deaths per year resulting from eating disorders. These numbers are often surprising to individuals who aren't familiar with eating disorders. Oftentimes there is an underappreciation of the morbidity mortality rates associated with eating disorders. So I thought it would be important to share that information. And as I was indicating when I was reviewing the objectives, the impact of COVID, frankly, for all mental health issues, has seen an increase in referrals and an increase in prevalence rates. Specifically for eating disorders, we've seen the same thing. And I will say within our clinic, we've seen a threefold, fourfold increase in the rates or the number of referrals. Over the last couple of years, we've also seen a little bit of a skew in the age of the referrals. For example, within our clinic population at UNC, We serve, just broadly speaking, individuals from the age of 10 with no upper age limit. Since COVID, and most recently since COVID, what we've seen is a bit of a skew of the ages of referrals, and we've seen a skew toward the lower age range, and we've even seen an increased number of referrals for a lot more patients who are below the age of 10. And again, another reason why I thought it was going to be important to talk about ARFID. This is not unique within our clinic at UNC. Whenever I talk to colleagues across the country, whenever I meet with colleagues at conferences, many have said the same thing, that they've seen just a skyrocket in the number of referrals. Inundation essentially is what a lot of individuals will describe, and a lot of frustration by pediatricians and primary care physicians who refer patients for eating disorder treatment, and are often found to be met with a wait list, and not just a small wait list, but a pretty long, extensive wait list. And even more so with individuals who have government insurance, so like Medicaid or TRICARE. The options for those individuals receiving or being able to access specialty care are far more limiting. So that's the context of what we've seen since COVID. And then this is just a depiction of a study that was published in Pediatrics in 2021. This is the impact within their clinical setting. So of course, the bluish, purplish dots are pre-COVID rates for eating disorder referrals or admissions per month. And then the dotted vertical line is the onset of COVID. And then you can see shortly thereafter the impact that COVID had on admission rates during each month. So another reason why we like to focus on eating disorders is that it has a significant public health concern. And so what we do know with the prevalence rates and treatment access for eating disorders is really only about 20 to 57% of individuals with an eating disorder receive treatment, and then less so for marginalized communities. And within this context, marginalized communities can relate to race, gender, ethnicity, insurance status as well, sexual orientation. Oftentimes with race, gender, sexual orientation, we find that those individuals can often go unrecognized, unidentified, and under or undiagnosed, which obviously leads to a delay in treatment and accessing treatment. And then what we also know around treatment is that when care is available, it's costly and often only available to individuals who are in large metropolitan areas and or for individuals who have commercial insurance. And broadly speaking, that's not to say that every individual who lives in a major metropolitan area has commercial insurance can access all levels of care. Sometimes even all levels of care are quite limiting in that they're not always available. And then the other thing that we have found is that not all healthcare providers are routinely trained to identify eating disorders and even treat eating disorders. And so one of our goals within the National Center of Excellence for Eating Disorders is provide that education and training, especially to primary care physicians who often don't have that training or background, and it's not from a lack of interest, they just often don't receive it. And that unbeknownst to them, they may be working with patients who may have an eating disorder and may not necessarily fit the stereotype or prototypical makeup of what they think an individual with an eating disorder would look like or present as. So the consequences of all these is that there's a lack of detection, there's a poorer prognosis, because what we also know is that the later somebody is identified, diagnosed, and referred to treatment, that contributes to a poorer prognosis. The earlier someone is identified, the earlier somebody's diagnosed, and the earlier somebody is referred for treatment, the greater likelihood that they have an improved prognosis in their treatment course. And then we also know that with that delay, there's the prolonged illness trajectory. And then, as I mentioned in a previous slide, there's the greater risk of morbidity and mortality associated with that. Okay, so it's a little bit of background of eating disorder prevalence rates and the impact of COVID and the importance of early detection, identification, and diagnosis. So at this point, I thought it would be a good time to review the eating disorder diagnoses. I'm not going to go into the detail that the DSM-5 has. Clearly, you can access the DSM-5 and look at all of the details. Instead, what I'm planning on doing is provide a very broad overview of the criteria associated with each of the diagnoses, and also discuss some of the associated features, because some of the associated features offer an opportunity for greater differentiation amongst the eating disorders. So the first one that we'll review will be anorexia nervosa. And the defining features are listed. Primarily, it would be an intense fear of gaining weight. And then that's also coupled with a restriction of food intake or energy intake. Usually, or it can present with a significantly low body weight relative to age, gender, sex, developmental trajectory, and physical health. So oftentimes, what we would like to see with individuals, especially older children, adolescents, and young adults, is their growth curves. So we could see how they've been tracking along the course of their lifespan to see in what way their weight loss has either allowed them to be consistent with their growth curves or vastly different. And so that's super helpful to identify and to map out. And then along the lines of the criteria is also a disturbance in the way one experiences their body weight, shape, or size. And oftentimes these criterion create a cycle that is a self-perpetuating cycle. There are two subtypes of anorexia nervosa. There is a restricting subtype, and then there's also a binge purge subtype. I'm going to talk about the definition of binging in a moment, but it's important to tease out from individuals which subtype of anorexia they may have. Oftentimes that may determine the course of a specific treatment intervention with regard to either food intake and or preventing any compensatory or inappropriate compensatory behaviors like purging behaviors. So as I mentioned in the previous slide, I do want to define binge eating. Binge eating is a definition that pops up in the diagnosis of anorexia nervosa within one of the subtypes. It also pops up in the diagnosis of bulimia nervosa, which we'll talk about in just a minute. And then it also obviously pops up in the diagnosis of binge eating disorder. So again, it's important to have a clear understanding of the definition of binge eating disorder, binge eating. So binge eating is defined by eating an unusually large amount of food in approximately 2 hours of time while experiencing a sense of loss of control over what or how much is eaten. So those two components are important. I will just name that quantifying an unusually large amount of food is somewhat challenging to quantify. And so in previous DSMs, there used to be a caloric amount associated with it. And I think in the DSM-3 and the DSM-4, if I recall correctly, it used to have, I think, approximately 200 calories associated with it. However, as food has changed over the decades, what we have found is that a caloric amount may not necessarily equate to an unusually large amount of food. And I'll just give you an example that's often used by some of our patients. If they decide to get just some generic fast food hamburger, a large French fry, and a large Coke, for example, they may well eat over 2,000 calories for that meal, but that wouldn't quantify an unusually large amount of food. And so it's important, again, to ask the patient questions about how they're defining the amount of food that they eat. And typically what we hear, the type of eating pattern that would be associated with binge eating would be something like a whole pizza coupled with a pint of ice cream, coupled with a sleeve of cookies, coupled with a large bag of chips. That would be an unusually large amount of food in about that 2-hour period of time. So you can easily see there's a distinction or difference between focusing on just the caloric amount versus just focusing on the quantity and what makes up the quantity of the food eaten. And then I thought it would be important to talk about the difference between an objective and subjective binge episode. Objective would be objectively, whenever you see or would encounter that amount of food, that would look like to most anybody a large amount of food. The example I provided with the pizza and the ice cream and the chips, etc., would be objectively a large amount of food to eat in one sitting. Subjective, oftentimes what we hear would be patients describing, well, I feel like I ate a lot. I felt like I was out of control. And when you parse out a little bit more and ask and query a little bit more, like what do they actually mean? They may say, well, I had 2 slices of pizza and then I had a dessert afterwards. And so subjectively, they may feel like they've eaten a large amount of food in a short amount of time, but objectively that may not quantify to a large amount of food according to the binge eating definition. So I know I'm going into great detail about that, but I think it's critically important to have a better understanding of the definition of binge eating. And then the features for binge eating, they need to endorse 3 or more of the following. So eating more rapidly than usual, eating until uncomfortably full, eating when not physically hungry, eating alone due to embarrassment or shame, and then oftentimes feeling disgusted, depressed, or guilty after the binge episode. So again, it's not just the definition, but it is also 3 or more of the following. So when I gave the example of the subjective binge of the pizza and the dessert afterwards, if an individual doesn't endorse eating more rapidly than usual, not eating or any of the following, maybe they may feel embarrassed or they may feel disgusted or depressed. It still doesn't meet that threshold of a binge eating definition. Okay, so let's talk about bulimia nervosa. As far as the criteria for bulimia nervosa, look at the very first one. It's binge eating. So remember that definition, plus compensatory behavior to prevent weight gain. And that compensatory behavior is often described as inappropriate compensatory behavior. Sometimes you'll see it in the literature as ICB, inappropriate compensatory behavior. And that can include behaviors such as self-induced vomiting, the use of laxatives or diuretics, any other type of medication, fasting, or excessive exercise. And the excessive exercise is not just exercise to enjoy exercise, but it is with the goal to prevent the weight gain. And then both the binge eating and the inappropriate compensatory behavior occur on average at least once a week for 3 months. In the DSM-5, this criteria has been changed in decades past. The frequency was a little bit more. And so I just want you to just pay attention to that frequency. In addition, self-evaluation is unduly influenced by body size, weight, and shape. And so if you think back to one of the criteria for anorexia nervosa, this is a similar criteria. So I want you to keep that in mind as well. And then this is also important. This is an exclusion criteria, but the binging or the purging does not occur exclusively during episodes of anorexia nervosa. And so one might go, well, yeah, if they're struggling with bulimia nervosa, then they're not struggling with anorexia nervosa. But I want you to keep in mind or remember that anorexia nervosa had 2 subtypes. So there's the restricting subtype, and then there's the binge purging subtype. And so it's important to maybe even tease out further to what degree someone might meet the criteria for bulimia nervosa versus anorexia nervosa binge purge subtype. And again, the DSM-5 has more specific criteria. This is more of a kind of broad brushstrokes of those differentiations, but I just want to point out where there are similarities and differences within and across the diagnoses. And then the third diagnosis that we'll review is binge eating disorder. This is recurrent binge eating episodes. So remember the definition of binge eating without the inappropriate compensatory behaviors. So that is how you differentiate bulimia nervosa from binge eating disorder. And then within binge eating disorder, there are severity ratings based on frequency. And so there's mild, moderate, severe, and extreme, where the binge eating episodes may take place between once a week up to 14 plus a week. And so you can use that as a marker to identify the severity of binge eating disorder. OSFED is another broad category, and I intentionally use the word broad. And so OSFED stands for Other Specified Feeding or Eating Disorder. So this, again, broadly speaking, captures eating disorders that may not necessarily meet the full threshold of the criteria listed for anorexia nervosa, the criteria listed for bulimia nervosa, the criteria listed for binge eating disorder. And for those of you who may be familiar with previous DSMs, the DSM-4 probably would have this as eating disorder NOS. Now, the problem with eating disorder NOS is that it ended up being a catch-all. At that time, binge eating disorder was within the context of eating disorder NOS. In the DSM-5, binge eating disorder is a standalone diagnosis, so it's not in this broad category the way it was in the DSM-4. But I'll give you an example of how these list different eating disorder diagnoses that don't necessarily meet the threshold of other ones. So for anorexia nervosa, if we review, I don't want to scroll through those slides, but one of the criteria for anorexia nervosa is having a low weight, having lost a significant amount of weight, where the weight is identified as low, and there are specific, like 85% of estimated body weight is that estimate for that. What we do know and what we've seen for the last decade, however, is that individuals in larger bodies, individuals who may be or have been premorbidly at a higher than average weight status, can lose a significant amount of weight, physiologically can look malnourished, physiologically can have the medical sequela that is often accompanied with anorexia nervosa, but may not be below 85% of estimated body weight. So atypical anorexia would be the diagnosis for that, and that falls under OSFED. And so it's a mechanism by which those individuals can be identified and referred for treatment. It's a mechanism by which the severity is also acknowledged as well. And there's been some recent debate as to whether or not atypical anorexia nervosa even needs to be a separate diagnosis from anorexia. So TBD, maybe in a few years, there may be a shift or change there. But that's an example of how a diagnosis may not fully meet the threshold of the previous diagnoses I have listed. Same with bulimia nervosa and binge eating disorder. It's less so about weight, and it may be more around the frequency or duration around the binge eating episodes. So just a couple of things to keep in mind when you consider OSFED. Now, for the remainder of the talk, I'm just going to check time for about the next 20 minutes or so. I thought we could spend talking about ARFID, so avoidant restrictive food intake disorder. We'll go through the criteria in the same way that we did for anorexia nervosa, bulimia nervosa, binge eating disorder. And then we'll also talk about some of the presenting ways that a patient with ARFID might be referred, some of the questions that come along with the referral for an individual who might have a rule out of ARFID, how one teases out the difference between ARFID and picky eating, and a whole host of common myths that are associated with ARFID. But as far as the criteria are concerned, the hallmark criteria is persistent failure to meet appropriate nutritional and or energy needs. And I want to differentiate ARFID from the other eating disorders that we've already reviewed, where one of the persistent features are either an undue influence of body weight, shape, or size, and or a fear of weight gain. in ARFID or with ARFID, neither one of those present as a persistent feature or an associated feature. So that's important to keep in mind as you're either performing a rule out or a differential diagnosis, or as you think about referring an individual for ARFID or receiving an individual for ARFID. There are three types associated with ARFID. One is a general lack of interest in food, just completely disinterested. If you put food in front of it, they may or may not eat it, but they're probably not inclined to seek out food for themselves or make food for themselves. Avoidance of food due to sensory characteristics. And so we see this a lot with younger patients. It could be sensory characteristics related to sight, color. It could be texture. Texture is something that we see quite a bit. And I think I mentioned taste. So different types of tastes might also lead to an avoidance. Whether something, another sensory one would be if something is soft, chewy, crunchy, etc. And then the third category is an avoidance due to an aversive experience. And the aversive experience, broadly speaking, what we've seen are two, with one that we've seen almost exclusively, and the one that we've seen more often than not and is an aversive experience related to choking. And so for younger children, it's not uncommon that they might have a choking episode. And for some of these children, the choking episode is so aversive that it may lead to a narrowing of food intake or food types. And so we see that quite a bit. And then the second aversive experience that we see as well would be a severe allergic reaction. And so those are kind of just some examples of the aversive experiences that we see. But those are the three subtypes of ARFID. And then the common features associated would be significant weight loss, or, as I mentioned earlier, failure to meet expected growth trajectory, nutritional deficiencies, and then in less common cases, a reliance on external feeding, so like tube feeding or nutritional supplements. Okay, so I'm just going to go into greater detail regarding the subtypes and then also talk about the characteristics where one or more would be required for the diagnosis. And so you can see a little bit of overlapping. And so what we often say sometimes is that children who may have a history of picky eating, may be a little bit more predisposed to developing ARFID, but you can see that there can be some overlap within the ARFID subtypes. However, as you really focus in on those subtypes, there's greater differentiation. And so I put in some quotes. These are quotes that we hear from younger children all the time. I just forgot to eat, and that would be so very common that we hear with the lack of interest subtype. And in all honesty, what we see is with ARFID, it's not exclusive to younger children or adolescents. We do see this across the lifespan. And an interesting subset of individuals, we're starting to get increased referrals for are older adults where just the lack of interest in food has set in. And so it's just interesting to look across the lifespan to see how these might present. But for the lack of interest, it's almost always I forgot, or I was too busy, or I just didn't even think of it. So when you hear words like that or descriptors around why they hadn't eaten, that's a signal to you that it might be the lack of interest subtype. With the sensory one, it would be ooh, gross, or ooh, that hurts, or ooh, I don't like, or no, I don't like crunchy foods. And it's a clear distinction of or an aversion of certain categories of food based on sight. Sound, sometimes smells is another one, and then texture. And then the fear of aversive consequences, almost like, but what if, or I'm afraid if. And so those are the things that we often hear with those subtypes. And I mentioned earlier the associated features. And so in order to meet the ARFID diagnosis, they would need one or more of those characteristics listed below. And then as far as rule outs are concerned, it's important to keep those in mind as well. Any cultural or religious influences or any food insecurity, you want to keep that in mind and think about that within the context of what the presenting issues are. And remember earlier, I said any eating disorder that's driven by influence of weight, shape, or size will not be an ARFID diagnosis at all. That's almost an exclusion criteria or exclusion characteristic. And so anytime you hear from an individual or a patient that that is an influence to the way they eat or the way they exercise, et cetera, then you are more likely going to be thinking about anorexia nervosa or bulimia nervosa, and then a little bit to a lesser degree, binge eating disorder. And then the other thing to keep in mind as a rule out is any kind of developmental or occupational therapy, speech issue that might be a skill dysfunction that may be the impetus for the pattern of eating. And so sometimes for some individuals, especially really young patients, primary care physicians and pediatricians may want to rule that out before providing the diagnosis of ARFID. And then for this slide, just as far as clinical characteristics, one of the things that we do see actually on the upper end of the age spectrum and the lower end of the age spectrum, when we think about eating disorders in general, although eating disorders can impact any gender, we often see more females diagnosed or present with eating disorder than males, with the exception of ARFID. And especially on the younger end of the age spectrum, we tend to see more males diagnosed with ARFID than females. So again, just something to keep in mind as well. On the upper end of the age spectrum, we tend to see a little bit more males than females who present with ARFID as well. Again, I'm not sure what that says. I don't know what that exactly means. I think this is just newer information for us to keep in mind. And then the longer duration of illness prior to seeking out treatment, as with any eating disorder, we know that the more entrenched the behaviors are going to be. So for younger patients, consistent with younger patients with eating disorders, we employ parents or caregivers, family members, to be the primary source of assisting with feeds and challenging some of the aversive consequences that the patient may present with. And then with all of the eating disorders and with ARFID as well, another characteristic is that there's a clinically significant impairment in day-to-day functioning. Okay, so I mentioned the age spectrum, and so I just wanted to have this visual that accompanies it, and then added some prevalence rates. And so for those that are 15 years or older, the prevalence rate is about 0.3%. And look at the prevalence rate and how it shifts for those who are between the ages of 8 and 13. That goes to 3.2%. So that is consistent with what we see clinically. It's consistent with what we hear anecdotally. And I'd actually be really curious to see, especially now that we're getting better at identifying ARFID in younger individuals, what the prevalence rates are for those that are under the age of 8. Okay, let me just keep track of time. Great, we are doing well. And so I've mentioned this as we've been moving along through the various slides, but I wanted to identify these opportunities for greater differentiation amongst the eating disorder diagnoses, and then even more so the differences between ARFID and the other eating disorder diagnoses. So ARFID is a feeding disorder, so it's in the category in the DSM-5 of feeding and eating disorders. It's not to say it's not an eating disorder, but it presents as a feeding disorder because the hallmark characteristic of the lack of influence of body weight, shape, and size or fear of weight gain is not present with ARFID. So that's why it veers over into a feeding disorder category more so than an eating disorder category. Nonetheless, it's treated as an eating disorder in the sense that the treatments employed would be consistent with what we would use for the treatment of eating disorders. And so again, for anorexia nervosa, bulimia nervosa, binge eating disorder, those are eating disorders based on the influence of body size, weight, and shape, the intentional restriction of food intake, or the intentional utilization of diet or restrictive eating practices. And then, as I indicated earlier, between ARFID and anorexia nervosa, it can be a little bit difficult to tease out, especially when there's lower weight or low weight that is present in both of those categories. And then the goals, as I mentioned with the treatment interventions, are the same, regardless of whether it's ARFID or AN, BN, or binge eating disorder. It's nutritional rehabilitation and weight restoration. And so those are the primary goals of treatment. And for those younger patients, for children and adolescents, the first line treatment is the utilization of the family in the treatment process. So again, I just thought this was a nice depiction of the different subtypes of ARFID. And also I thought it would be important to talk about some of the characteristics that co-occur with ARFID. So about 50% of individuals with ARFID may also have co-occurring anxiety disorders, mood disorders. Interestingly, internet gaming disorder, which you don't often see as a co-occurring disorder with some of the other eating disorders. What we're also starting to see is an overlap between ARFID and other neurodevelopmental disorders. So a higher prevalence rates of individuals referred for ARFID who also have autism and who also may have ADHD. And if we think about autism spectrum disorder and ADHD, those prevalence rates gear toward higher rate of males to females. And so it kind of makes sense that for the younger patients, we would see more males with ARFID than females. But again, this is just emerging information, and I anticipate in the next 5 to 10 years, some of this information might be further refined, and we might see something a little bit more detailed or nuanced in these characteristics and associated features. Okay, so for other characteristics regarding the co-occurring medical concerns, for individuals being at a persistently low weight, we do have a concern for low bone density. It's the same concern that we would have for individuals who present with anorexia or even atypical anorexia nervosa, electrolyte imbalance. We would see that with anorexia nervosa as well, and with bulimia nervosa, specifically with purging behaviors. Chronic abdominal pain, that is something that we see more often as a presenting concern with ARFID than with the other eating disorder diagnoses. Oftentimes we see abdominal pain or GI upset with anorexia nervosa, bulimia nervosa when they start consistently refeeding themselves or engaging in the refeeding process, but not before treatment is started. And then there's a higher co-occurrence of gut-brain interaction, so functional GI disturbances as well. And then I mentioned the comparison with other eating disorders, some of the similarities and some of the differences as well. So in my slide, I think where I talked about the objectives for today's talk, I thought it was going to be important to differentiate ARFID from picky eating. So this is one of the reasons why ARFID can go undiagnosed or misdiagnosed, or an individual with ARFID may not receive a diagnosis of ARFID and may receive a whole host of workups to rule out all sorts of other disorders, especially GI-related disorders, because there is this thinking or belief that younger children just typically present with picky eating. Younger children can present with picky eating, but picky eating may contribute to ARFID. ARFID is not just picky eating. And so what we do know is with picky eating, there's just an unwillingness or resistance to trying different foods or foods that they're not familiar with. And there can be just a limited variety. And that is very common. We see that in peds between 50 to between 15 and 50% of the pediatric population, but the peak of picky eating is around 3 years of age, especially with a family or a caregiver's persistence in presenting and offering foods of lots of variety, of course, over the course of the childhood experience. The majority of youth with picky eating will show appropriate growth trajectories over time. Individuals or patients with picky eating usually are not persistently and consistently low in their growth curves, whereas with individuals with ARFID, they may be more likely. And then picky eating is very easily managed with the PCP. And again, it's just employing families to present lots of food options with lots of variety. And what we also see with adult ARFID is that it presents more so than picky eating in adulthood. And then, yes, I just wanted to say there's still more to learn around the greater differentiation between ARFID and picky eating. And so again, if somebody is in a position where they're not really sure if the eating pattern is out of just pickiness or selective eating versus ARFID, the subtypes of ARFID are going to be your guiding force. And so is the picky eating related to sensory issues? Is the picky eating related to just an overall lack of interest? Is the picky eating the result of an aversive consequence or is an aversive situation? Again, that's kind of a broad way to start teasing out what's picky eating and what's ARFID. Is ARFID a pediatric feeding disorder? No. And there's a lot of overlapping areas for sure. And so what we do see with pediatric feeding disorders is that there is an impairment in oral intake that is not just age appropriate and can be associated with medical, nutritional, feeding skill issues and psychosocial dysfunction. And so oftentimes there is an emphasis on medical problems and or developmental delays. Sometimes we see this a little bit more with autism. And then sometimes it may be a GI diagnosis. And then I'm noticing that we're almost at a quarter of the hour. So I'm just going to start moving through the slides. If I can maybe have 3 to 5 more minutes to go through slides and then transition to Q&A. So for the treatment of ARFID, these are the various levels of care. Obviously, the younger the patient is, the more likely we want to avoid the use of higher level of care. And frankly, for any adolescent, we would want to avoid the use of any higher level of care that would take them out of the home. So usually higher level of care is an indicator when there's a significant medical concern and or if there are other co-occurring diagnoses that warrant a primary intervention such as suicidal ideation. So I'm not going to go into great detail about the different levels of care, but more often than not, ARFID can be treated on the outpatient level of care, especially with the heavy involvement with families and or caregivers. There's some early pharmacological interventions that are looking promising, and these are listed below as well. And these usually assist with either managing or curbing off the anxiety that's associated with any kind of exposure to food and or the anticipatory anxiety of an aversive consequence. So the treatment itself for ARFID is cognitive behavioral therapy, and I have on here the treatment manual for that. It does involve family, so it's a family, there is a family-based component to it. And if you look at the depictions, you can see here for those who present with, let's see, in each of these, there's an approximation. So a gradual exposure to either variety, size, shape, and or actually tolerating the food in the patient's mouth. And so it's not the details that I want you to be familiar with, but it's more so the concept of exposure, where you start off either with something very familiar, very comfortable, and or something proximal toward the mouth. So not even in the mouth yet, but kind of near the mouth. And the philosophy with exposure is that you get closer and closer and closer in a graduated fashion to the food or the mechanism by which you want them to be able to eat. So we'll briefly go through a case example. Again, I know we're coming up on time. We're not going to go into great detail. Spoiler alert, this is going to be a case example that has the answers already in there. So it's not like I'm going to leave y'all in suspense, but I thought it was just good for an example. So this is just a common example, and this is a conglomeration of lots of the way different patients have presented. So an adolescent female presenting to the GI clinic, oftentimes with ARFID, an eating disorder clinic is not the primary referral. It is often a GI clinic or their pediatrician. We're sometimes secondary or even tertiary. So an adolescent presenting to the GI clinic with an onset of abdominal pain, constipation, and intermittent nausea. There's a thorough workup, and lo and behold, the patient received a diagnosis of IBS with constipation, or the constipation subtype. And then also the patient received a diagnosis of generalized anxiety, which importantly predated the GI symptoms. I think that's another important component. It's probably a talk for some other day. But when you're thinking about mood or anxiety disorders within the context of an eating disorder, it's important to tease out whether or not the mood and anxiety symptoms predated the onset of any eating disorder behaviors. And that is a hallmark that it's a standalone diagnosis versus one that might be related to malnutrition or something like that. So eating related symptoms, for her, the patient presented with an elimination of foods, perceived to trigger GI symptoms. Remember, the abdominal pain were the GI symptoms with some intermittent nausea and constipation. And so her attempt was reducing portion sizes. This resulted and or presented concurrently with a loss of appetite. The fear of eating facilitated the loss of appetite. And again, you have this cyclical pattern that's starting to set in, to the point where she had food restriction such that she was consuming about 400 calories per day over the course of about 6 months and required supplements. She denied any weight, shape, or concerns. And that bullet is important because of why. Again, that's the associated feature with anorexia nervosa, bulimia nervosa, or binge eating disorder. And so with that, we can automatically exclude those other eating disorders, and we can keep in our differential ARFID. Other medical symptoms is that over the course of this time, about 6 months, she's lost about 20 pounds. She also has presented with amenorrhea, and then she's also reporting a great deal of fatigue. So I just want you to kind of look at this cluster of reporting and symptoms and just think about how patients might present and what questions you might have, whether or not it's a question as related to wanting to rule in or rule out ARFID, or if you are already solidly on ARFID, what subtype you might want to consider and what questions you might want to ask. So just some more presenting information. This is her typical intake for breakfast, lunch, and dinner. Again, she's denied shape or weight concerns. She's denied overeating disorder behaviors. She's actually expressed a desire to gain weight, such that she can engage and participate in athletics. So there's no fear of weight gain that is present for her. Again, another differentiating feature there. And then as far as any other mood or anxiety co-occurring diagnoses, she's reported low mood and energy, but that's been as a result of or within the context of eating difficulties. Again, just this other part, improving with refeeding, just lets you know that over the course of refeeding, any low mood or fatigue has dissipated, and the anxiety did predate eating disorder concerns. So the anxiety wasn't the result of eating disorder concerns. with the exception of the fear of nausea and abdominal pain, but that's not generalized anxiety. So what the treatment looks like, the treatment is a multidisciplinary approach involving the GI physician, a therapist, a dietitian, psychiatry as well for medication management, adolescent medicine, and a pediatrician. There's some pharmacological opportunities to assist with the anxiety, also to assist with constipation. And then the non-pharmacological interventions with the dietitian would be expanding the variety of food intake and the quantity of food intake by using chaining. Again, the chaining is similar to exposure. You're going to start with where they are and progressively move forward to where you want them to be. And then the therapist would be targeting coping around GI symptoms, which involves some diaphragmatic breathing, and we can teach the patient to do that, anxiety management, and then also tolerating, working toward increasing food intake. And then this is just a little bit more about the treatment and then some examples of how CBT and FBT can be combined. Again, family involvement is critical for children and adolescents, primarily within the context of feeding, but also providing additional support around meals and assisting with any kind of negative emotions or physical consequences related to increasing food intake. And then just the treatment outcome for this case. She is now eating 3 meals and snacks daily with improved variety. Weight has been restored. Remember, she had about 20 pounds that she lost that she needed to regain. There's a great deal of improved understanding around eating patterns and GI distress. She's also gained skills and being better able to manage anxiety. And her social impairment is no longer an issue as she's able to eat much more flexibly, spend a lot more time with friends in eating situations. So she's not eating in isolation anymore. And then within the context of the IBS with constipation, there's been improved pain management and a tapering off of some of the medications that were initially utilized. So as far as resources are concerned, I did not go into frontline treatment for anorexia nervosa, bulimia nervosa, or binge eating disorder because I really wanted to focus on ARFID. However, I've included resources that do talk about those. So the Academy for Eating Disorders has a lot, there's several guidebooks that they have targeting different components or different consequences related to the eating disorders. So in the upper left quarter is the Eating Disorders Guide to Medical Care. So there's a lot of information there as far as medical interventions, medical assessment, across the various eating disorder diagnoses. Similarly, there in the upper right corner, there's one for the psychological therapies. So you'd be able to search that. There's an electronic version for all of these. You can search that for the treatment of anorexia nervosa across the age span, similarly with bulimia nervosa and binge eating disorder. And then there's the bottom center is the nutritional treatment guidebook as well. And then these are additional resources for not just ARFID resources, but other eating disorders as well. And then I think we have 5 minutes for Q&A. So apologies for going over. I just thought it would be important to just spend a little bit of time talking about the case in a little bit of greater detail, particularly around differentiation across the eating disorder diagnoses.
Feel free to unmute yourself or type a question in the chat.
Hi, good afternoon. Just wanted to say thanks for your talk. A lot of really good information. So I have some experience working with eating disorders, and usually by the time they get to a specialty clinic, a lot of the times they're really far into their disorder because referrals at earlier stages haven't gone well. So I'm wondering if you can speak to kind of overcoming resistance and denial during that referral stage to try to help people get into treatment earlier?
That is a great question. And so I think, unfortunately, what we often do is place the onus on the patient and or family to acknowledge that there's a problem. And sometimes they don't even realize that there is a problem within the context of potentially having an eating disorder. And we can go into great detail about that. Sometimes it's related to shame or guilt. Sometimes it's just a byproduct of being underinformed or not educated about what an eating disorder looks like, or even how an eating disorder can present at different ages, different genders, etc. So I'd like to say the onus should be on providers, and the onus should be on providers in educating or providing that education to patients and families. And so validating that they may not be thinking or endorsing that they would have an eating disorder, yet from our view, the clinician's view, these are the various things that would indicate to us that an eating disorder is likely on board. So I think it's a marriage of both of those. One is acknowledging that the patient or family may just not have that information. And coupled with that, there may be some shame or guilt associated with it. And then two, the onus of the education is on us as clinicians. We just globally need to do a better job. In the same vein that we're really great at educating patients and families around mood disorders, anxiety disorders. For pediatricians and primary care physicians, they're masterful at providing education around medical diagnoses. So eating disorders shouldn't be any different. It's a great question.
Yeah, thanks for your comments on that.
Mhm.
Any other questions? And just a reminder, links in the chat for evaluation and whatnot to complete. Well, we are at about 1 o'clock. Thank you so much for the great presentation. And it was great information. And again, please be looking at your email. I'll send out the slides. And so you'll have those resources on there as well. And a link to the evaluation in case you didn't get a chance to complete that today.
Thank you for having me and giving me the opportunity to talk about pediatric eating disorders.
Thank you so much.
Okay,
Bye.
bye-bye.